Okay, moving on to the next presentation. We will be joined momentarily with another one of my favorites from the world of PKD, Dr. Lisa Guay-Woodford. She will be speaking today on the basics of clinical care for children with both ADPKD as well as ARPKD. Today's presentation, Dr. Lisa Guay-Woodford will be presenting the basics of both those and current ARPKD research and clinical trials as well. Dr. Guay-Woodford is an internationally recognized pediatric nephrologist whose work focuses on identifying clinical and genetic factors involved in the pathogenesis of inherited renal disorders, most notably autosomal recessive polycystic kidney disease, or ARPKD. Her lab participated in the identification of the human ARPKD gene as part of the International Consortium, and her group was the first to identify a candidate modifier gene for ARPKD. She has directed the NIDDK-funded Hepato-Renal Fibrocystic Disease Research and Translational Core Center, initially established when she was at the University of Alabama at Birmingham, and she continues to serve as co-director of the UAB Childhood Cystic Kidney Disease Core Center. Her research program has been funded by the NIH, the Burroughs Wellcome Fund Clinical Scientist Award in Translational Research, and the PKD Foundation in the United States. In 2009, Dr. Guay-Woodford was awarded the Lillian Kaplan International Prize for Advancement in the Understanding of PKD, given by the PKD Foundation and the International Society of Nephrology. Dr. Guay-Woodford has recently assumed the role of Senior Advisor for Clinical and Translational Research Initiatives and Director of the Inherited Kidney Diseases Program at the Children's Hospital of Philadelphia. She holds the Presidential Scholar Endowed Chair for Clinical and Translational Science and serves as Professor of Pediatrics at the Perelman School of Medicine at the University of Pennsylvania. Dr. Guay-Woodford, it's Christmas early for me, getting to spend some time with you. I'm so glad to have you here and really appreciate you taking the time to join us here in Canada and around the world with all the attendees.
Thanks so much, Jeff. And so you folks have my video?
We have it all queued up, and we will join you for the live Q&A right after.
Terrific. I'll look forward to it. Hello, I'm Lisa Guay-Woodford from the Children's Hospital of Philadelphia. I'm delighted to be part of the 2023 PKD Summit, sponsored by the PKD Foundation of Canada. My topic for today is the basics of clinical care for children with ADPKD and ARPKD. In terms of disclosures, I serve as a consultant for Otsuka Pharmaceuticals and Natera Incorporated. I've organized my talk today in a series of sections. The first is to provide you with an overview of normal kidneys and normal liver and their functions, and also to give you a brief primer about genetics, essentially to set the stage for our discussion about PKD in children. I'll start by talking about ADPKD, the dominant form of polycystic kidney disease, and then segue into a discussion of ARPKD, the recessive form of polycystic kidney disease. And then in the last part of my talk, I'll focus on three areas that historically have been of great interest to audiences like this: nutritional needs and challenges for children with PKD, how to develop a healthcare team for your child, and then how you and your child can contribute to advancing new knowledge in childhood PKD. So let's start with an overview. The normal kidneys are a pair of reddish-brown organs that are located on either side of the spine just below the diaphragm and behind the liver and stomach. And they truly are bean-shaped, about the size of one's fist. The primary function of the kidneys in this garden hose-like structure called the nephron is to remove waste from the body through the production of urine. The kidneys are also really important in regulating blood pressure, blood volume, and the chemical composition of the blood. So how do the kidneys maintain health? Well, they remove waste and excess fluid from your body through the production of urine. And in this way, they continuously regulate the body's fluids and chemical composition in terms of sodium, potassium, phosphorus, and calcium levels. The kidneys remove many drugs and toxins from your body. And they also produce and release hormones into your blood, such as erythropoietin, which stimulates bone marrow to make red blood cells, renin, which regulates blood pressure, and calcitriol, which is a form of vitamin D that helps the intestine absorb calcium from the diet and thereby maintain healthy bones. Critically important for growing children. This is a schema to sort of drive home the point about how the kidneys are so smart in handling salt and water. So in this garden hose-like structure, the nephron, blood is filtered as indicated by the arrow. And in a normal adult, about 1,500 grams of salt are filtered per day, but only about 6 grams are actually excreted in the urine, meaning that less than 1% of the filtered load of salt is excreted, because the kidneys are very sophisticated in being able to reclaim from the fluid as it courses through this garden hose-like structure the salt that the body needs to hold on to, and in situations of excess salt, to get rid of that excess salt. Similarly with water, the typical adult filters about 200 quarts of blood per day, and that filtrate is condensed down to about 2 quarts that are the daily urine output for an adult. So only about 1% of all the filtered fluid is actually lost in the urine. In terms of the liver, it's one of the largest and most complex organs in the body. It weighs about a pound and is made up of a spongy mass of wedge-shaped lobes. It has many functions which are essential for life. It helps process carbohydrate, fats, and protein that are absorbed from the intestine, and it turns them into materials that are essential for life. It secretes bile to help digest fats. It makes factors that are needed for clotting. It stores vitamins, and it breaks down toxic substances in the blood. Now, the liver really has 2 major components. The brick red substance at a cellular level is referred to as hepatocytes. Those are kind of the synthetic, the factory part of the liver. And then the part of the liver where you see the bile ducts, that is the bile duct network that is actually the part of the liver that's disrupted in polycystic kidney disease, as we'll talk about in a minute. Now, I think we need to just spend a few minutes thinking about genetic terms. So there are about 20,000 genes that we have in each of us, and they're organized as paired copies, one from the mom and one from the dad. And these paired copies are in turn organized on chromosomes. These genes are distributed to new offspring in an entirely random fashion. So for dominant disorders, let's say the father is carrying the disease copy of the gene indicated in red, there's a 50% chance in every one of his offspring that he will transmit that red copy, that defective copy, to that offspring. And in the cartoon shown on the right-hand side, that defective copy was indeed transmitted to his son, who is now also affected with this dominant disorder, whereas his unaffected daughter got the normal copy of the gene. It's entirely different in the recessive form of the disease, where each parent is carrying a defective form of the gene, but just one abnormal copy isn't sufficient to cause disease. And again, random segregation, such that the affected boy was inherited from his father as well as his mother the defective copy of the gene. And his unaffected sister either affected an abnormal copy from one parent or from each parent the normal copy of the gene. And so this is the dominant disorder that we recognize in polycystic kidney disease and the recessive disorder we recognize in polycystic kidney disease, fundamentally different genetic mechanisms. So with that as the backdrop, what is polycystic kidney disease? Well, for children, it primarily affects the kidney and sometimes the liver as well. And the structure that's primarily involved in the kidney is, again, that garden hose, that nephron structure that is so crucial for how the kidney functions. And in the liver, it's not the brick red synthetic factory portion of the liver. It's the bile ducts and the structures around them that are infected. So said another way, children and, as a matter of fact, adults with polycystic kidney disease don't typically have trouble with the synthetic functions that the liver normally controls, but it is in terms of the bile duct structures, the flow of bile, the pressure in the venous system around the bile ducts that causes concern. Now, the reason that I think we have moved to discussing polycystic kidney disease in genetic terms is because we used to refer to these disorders in terms of the age at which most patients were affected. So, for dominant polycystic kidney disease, most patients historically have come to medical attention in adulthood, and so it's been historically referred to as adult polycystic kidney disease. But as a pediatric nephrologist, I know, and perhaps some of you in the audience know, that ADPKD, the dominant disease, can manifest even in prenatal situations and certainly in infancy. And so it would be a misnomer to call those affected infants as children who have adult polycystic kidney disease. It's more appropriate and actually more accurate to say they have autosomal dominant polycystic kidney disease. Similarly, the recessive form of polycystic kidney disease typically affects or typically manifests very, very early in life. And so historically it's been referred to as infantile polycystic kidney disease. But again, there are adults that come to medical attention for the first time after age 20. And so for them, calling this disorder infantile polycystic kidney disease just doesn't make a lot of sense. We more accurately describe this disorder by its genetic designation as recessive polycystic kidney disease. So let's dive in and talk in more specific detail about ADPKD. This is a disorder that has a worldwide prevalence of about 1 in 800 to 1 in 1,000 individuals. There are two principal genes that are disrupted in ADPKD. PKD1, which accounts for about 78% of the cases, and PKD2, which accounts for about 15% of the cases. In recent years, two additional genes account for another few percent of the cases of ADPKD. Typically, these are patients who have defects in these genes have a milder course of disease. And then in addition to these 4 genes, there are another 4 or 5 genes that are really even more rare as causes of ADPKD. But all these patients have the typical fundamental abnormality. They differ to a certain extent in the severity of that abnormality. In children and adults, 1 to 2% of the nephrons are affected with these soap bubble-like cysts shown in the upper right-hand panel. And these soap bubble-like cysts can be very small, such that the kidneys stay normal in size, or they can be really quite large and quite numerous, leading to the kidneys to be very, very large in size. In terms of other associations, there are patients with ADPKD that can have biliary cysts or pancreatic cysts, vascular aneurysms, including aneurysms in the blood vessels of the brain, hernias such as inguinal hernias, and in a subset of males, infertility. But by and large, these other associations are seen in adults and not affected children. This is a very nice table that I took from a review from many years ago, but it still is really sort of accurate. There are 3 major forms of ADPKD. The classic adult onset ADPKD that many of you are aware of, the childhood onset ADPKD, and that's the middle group. And here I'm referring to children not just who have an ultrasound, come from a family who is known to have ADPKD, has an ultrasound, and you see a few cysts. These are children who come to medical attention because they have blood in their urine, or they have protein in their urine, they have high blood pressure, rarely they have kidney stones, and interestingly, in little boys, they have a higher frequency of inguinal hernias than their age-matched counterparts who don't have ADPKD. And then finally, as shown on the left-hand side of this diagram, of this table, there are children with early onset ADPKD that come to medical attention very early in life, prenatally or around the time of birth. And these children have a very accelerated form of ADPKD that can lead to loss of kidney function and end-stage kidney disease during childhood in about 25% of them. Now, these children can have the same defect in a ADPKD genes, typically PKD1, as their family members who came to attention much later in life. And we don't still really understand what distinguishes these children with very early onset from their adult relatives who come to medical attention, as I said, in late adolescence or early adulthood. Now, when we think about management of kidney issues, they're listed for you there under manifestation and the management in terms of the current state of the art, the current state of the clinical science in terms of managing ADPKD. But these guidelines come primarily from adults because this is the cohort of patients with ADPKD that has been most rigorously studied. So we as pediatric nephrologists, in the absence of data, borrow from these adult data in terms of treating hypertension, abdominal and flank pain, which can be a major issue, particularly for adolescents, hemorrhage due to cyst rupture, kidney stones, which can happen in children, cyst infection, progression to end-stage kidney disease, again, those children with early onset ADPKD, this is a major issue for them during childhood. Renal cell cancer, really not very much of an issue at all for children. This really largely is in the purview of adults with ADPKD. And then in terms of newer insights into how we monitor the progression of the disease in terms of total kidney volume, and you've heard about this from the PKD Foundation of Canada website and from some of the presentations in the annual meetings like this one. This is largely in the purview, again, of adults with ADPKD. We have not yet come to a clear consensus of how we can monitor cyst growth and cystic kidney disease progression in children, but we are certainly making progress. When we think about management recommendations, there was a really wonderful international consensus work group that published a couple of years ago a statement on the diagnosis and management of ADPKD in children and young people. And essentially it falls into three major recommendations. Children with a positive family history should be monitored for hypertension, high blood pressure, by continuous blood pressure monitoring. We call it ambulatory blood pressure monitoring. They should also be monitored for the presence of albumin in the urine. It's not recommended necessarily that all of these children be screened by imaging studies, and certainly not imaging studies at any given age. And I certainly would be happy to discuss that when we get to the questions and answers. In terms of thinking about children who have high blood pressure, have protein in the urine, or have an accelerated kidney function that we refer to as hyperfiltration, there is a specific class of drugs called ACE inhibitors that are recommended as first-line therapy for children with ADPKD. ACE inhibitors are the pril drugs, captopril, enalapril, lisinopril. And we have lots and lots of experience with these drugs in children so that they're effective and their safety profile is well known to us. And then finally, children with ADPKD should be strongly encouraged to achieve a low dietary salt intake. And this is really what's recommended for all children. And we'll talk about this a little bit more at the end of my presentation this afternoon. When we think about targeted therapies, how do we get at the crux of what goes wrong? I have to show you this wiring diagram. It's a wiring diagram of a cell that shows different pathways or different circuits, if you will, that are disturbed in ADPKD. And so targeted therapies aim to kind of correct the disturbance in this wiring diagram. The first, and perhaps best studied, is cyclic AMP, which is a second messenger that's really important in driving a lot of processes within an epithelial cell, the cells that line the tubes of the kidney and the tubes of the bile ducts. Cyclic AMP production and regulation is disturbed in polycystic kidney disease. And that disruption does in part involve the V2 receptor. And that's important because the V2 receptor is on the bottom of the cell. It kind of acts, if you will, like a lacrosse stick or a baseball glove, and it catches the ball that is vasopressin. That whole sort of ball receptor kind of pathway is abnormal in ADPKD, such that cyclic AMP production is driven up. And the drug tolvaptan or Jynarque essentially makes that glove or that lacrosse stick unable to catch the ball, and so lowers the intracellular concentration of cyclic AMP and can slow the rate of progression of polycystic kidney disease. Similarly, the mTOR pathway can be very important in causing these cells to multiply at a faster rate. And there are drugs called the rapalogs. Perhaps the most well recognized is a drug called everolimus that can block the dysregulated mTOR pathway in these patients, at least theoretically. It certainly works in animals. And then finally, there is abnormal signaling at the surface, at the fluid-facing end of the cells, and that is a regulated process by a class of receptors called tyrosine kinase receptors, and a class of drugs, tyrosine kinase inhibitors, can block that abnormal signaling. So these are very targeted therapies that get at what's wrong in the wiring diagram of a cystic epithelial cell. So how do we think about them for children? Well, tolvaptan has been used in children with ADPKD, and here's a really important case study from the UK. A little girl was born with 2 copies, not 1, 2 copies of an abnormal PKD1 gene, and she had huge kidneys, hypertension, low levels of sodium in her blood, and real problems in terms of breathing on her own. There were several of us who talked with her treating nephrologist around this time. And he opted to go ahead, because she was in such a medically difficult situation, to treat her with tolvaptan. Again, that drug that blocks the lacrosse stick from catching the vasopressin ball. He treated her for almost a year. Her low levels of sodium got better, her high blood pressure got better, and her accelerated growth in her kidneys was really slowed down. And she tolerated the drug well. So we have at least one case, and it's an important case, where this drug was used as targeted treatment in a child who had very severe disease. It was well tolerated, and importantly, it slowed the rate of progression of her disease. So how do we think about recommendations for new therapies in children with ADPKD? Well, this V2 receptor antagonist, tolvaptan, should not be offered routinely. It's not an easy drug to take, as many of you who are adults and taking this drug know. It can be used off-label in selected children, case in point, the little girl that I just discussed. In terms of statins, another drug that many of you as adults with ADPKD who are in the audience, that's a major part of your management. There's no consensus about the use of statins in children. And then finally, while mTOR inhibitors and other drugs that act on the V2 receptor have been shown to be efficacious in animal models, these drugs are not recommended in human patients, and certainly not in children with ADPKD. So let's switch now and talk about the recessive form of polycystic kidney disease, ARPKD. It's much less common disorder than ADPKD, occurs in about 26,500 live births. The molecular genetics are less complicated. The overwhelming number of patients have mutations in PKHD1, is the major disease-causing gene. There are patients, a small number of patients, that have mutations in 1 of 2 other genes. The kidney disease is also quite different. It isn't a soap bubble disease, it's a dilatation of the last portion of the nephron, the so-called collecting ducts. But this dilatation can lead to massively large kidneys. And in addition, this is a disorder that even in children can have a biliary abnormality, because the bile ducts themselves don't form normally. We call this biliary dysgenesis. And as a result of this abnormal development, there is associated fibrosis, which we recognize, as I'll show you in just a minute, as congenital hepatic fibrosis. So here is a set of diagrams that show the kidney disease. The middle panel shows the dilatation of the collecting ducts, And the far right-hand upper panel shows the massively enlarged kidneys. Now, you'll recall I said that the kidneys should be about the size of your fist, and that really is more or less true through the lifespan. You can see that these kidneys are really massive in size, and they're from an unfortunate child who died of ARPKD in the newborn period and had kidneys that measured upwards of 6 centimeters. So massively, massively enlarged. In the liver, that lattice-like network of bile ducts shown in the lower left-hand corner, that whole developmental program doesn't complete in a normal way. And so the bile ducts are abnormal and chaotic. It leads to associated scarring. That's shown as sort of a slice through the liver, looked at under the microscope. And the consequence you can see in the lower right-hand panel, the blood should be moving through the blood vessels into the liver, but the pressure, because of that scarring, can increase. And remember, these are veins. They're very thin-walled structure. They can't tolerate that pressure. And so when the pressure inside the liver due to congenital hepatic fibrosis becomes too high, the blood then backs up, not going through the liver, but then distributing to the stomach, the esophagus, and the intestines. And that's a picture that we recognize as congenital hepatic fibrosis. Now, there's been a lot of debate about how common ARPKD is, and perhaps even more importantly, what the mortality is for newborn children. So people have said it's incredibly rare, and so it would be very, very hard to ever do a clinical trial because there are just too few patients. And there's lots that I'm sure many of you who have children with ARPKD found in your look through the Google, that more than 60% of these children die in the newborn period. So, colleagues of mine and I tried to examine the medical record to kind of get a more accurate sense. First, how many patients are born with ARPKD? How many die in the newborn period versus survive? And therefore, how many patients are there in the United States who are children, adolescents, and young adults? And the data are shown on the left-hand side as a summary. So the incidence is about 1 in 26,500 live births. The perinatal mortality rate is about 21%, or said another way, 21% of these children die in the newborn period. And the prevalence, or how many patients are there currently living in the United States with ARPKD, it's about 1,500. So actually a relatively large number of patients for a rare disease that could be available, could be interested in clinical trials to make that further progress towards targeted therapies. When we think about patient survival, these are two sets of data, one from our group and one from the Mayo Clinic, that make the same point. For children with ARPKD, there is mortality. This mortality is largely an issue in the newborn period, and if children survive the newborn period, they can live a very, very long time in the Mayo Clinic study, well into adulthood, before there is the next mortal event. In terms of clinical features for newborns, for reasons we don't understand, these children are typically born after the spontaneous onset of labor at 34 to 36 weeks gestation. So they're just a little bit premature. In part because of their prematurity, but mostly because of their poor lung development. There is a 21% mortality based again on our electronic health record study. And in the newborn period, their major problems are due to their kidney disease. Low levels of sodium in the blood, so-called hyponatremia, decreased kidney function, very large kidneys, and even high blood pressure. As children get a little bit older, they can have chronic lung disease, although it is surprising for children who have such poor lung development by and large that the prevalence of chronic lung disease in the children who survive the newborn period is not really that high. And it's an issue that we don't completely understand. The kidney issues now are electrolyte abnormalities, hypertension, and declining kidney function. The liver, portal hypertension. Because of the portal hypertension, their veins around, particularly the esophagus, can become quite dilated, and they're thin-walled structures, so they can rupture and bleed. And then in those abnormal bile ducts of the liver, it can be subject to not having good clearance of the bile. The bile is sitting there as a very nutrient-rich fluid, and bacteria can move from the intestinal tract into the liver, into those lake-like bile ducts, and cause an infection that we call cholangitis. Feeding can be a real issue for these children, probably contributing to the poor growth that we see in a subset of these children. And in a series of case reports, there is a small but definite number of children with PKHD1 related disease that can develop abnormalities in the blood vessels of the brain, aneurysms. We call them in the brain intracranial aneurysms that can be medically quite worrisome. This is not as big a problem in ARPKD as it is in adults with ADPKD, but it's a newly recognized issue that we as pediatric nephrologists have to be mindful about. When we think about clinical management, the prenatal diagnosis is important but not invariant for these children. When we manage these children, we have to think about their low blood sodium. This is because not that they're losing too much sodium, but it's because they're holding on to too much water. And so in the newborn period, we may treat that level of sodium by giving them sodium. But after a few weeks of life, we have to reassess, because again, it's not a problem of them having too little sodium, it's having too much water. So if we can get rid of that water, we can make the sodium level come up, because it's a concentration of sodium. High blood pressure is a very common and sometimes very thorny issue to deal with in these children. Urinary tract infection, chronic kidney disease, progression to end-stage kidney disease, growth issues, as I mentioned, portal hypertension, and then also the issue of survival. Survival, again, if you survive the newborn period, these children tend to survive for many, many years. There is new knowledge that is sort of rapidly developing from clinical databases, and I'll talk about those in just a minute, but I wanted to show you this data because the question for families that have had one child with ARPKD or where this is a prenatal diagnosis for the first time is clearly focused on what's going to happen to my child. And in a database study, or a study from a database that Max Lebo and colleagues have organized in Europe that now includes over 700 children with ARPKD, the combination of having oligoanhydramnios, so very low amniotic fluid, enlarged kidneys and renal cysts, children who had that complex of features had a 32% risk of needing to have dialysis or renal replacement therapy by 12 months of age. Whereas children who did not have all three of those features, so that's sort of at the very top of the list, had only a 1.5% risk of needing dialysis by 12 months of age. And when we follow that out to 36 months of age, 34% risk of dialysis by 36 months of age, if you had all three features, and only about a 1.7% risk. So it's not just having the gene defect that suggests that you're going to have a risk for a decline in kidney function, but now we are beginning to tease apart clinical predictors of a rapid decline in kidney function. So having talked about ADPKD and ARPKD, let's go back to bundling PKD in children as a topic and consider nutritional needs and challenges for children with PKD. So let me start with nutritional considerations for the family. This is the anatomy of a kidney-friendly meal. For those of you who have ADPKD, the family embraces these considerations because, you know, the family that dines together stays together. And this is a chart from an American website. I'm sure that the Canadian websites are very similar. You know, a high percentage of fruits and vegetables, carbohydrate, particularly whole grains, and proteins. Perhaps a combination of animal-based protein and plant-based protein. This constitutes a kidney-friendly diet. And how do you think about the diet? Well, there are probably, for people who have high blood pressure or people who have a combination of high blood pressure and decreasing kidney function, there are four really critical features on nutritional labels to look at. The first is the serving size, because we know that being overweight is a risk factor for more rapidly progressive PKD in adults. So you open a package, you say, oh, I can eat the whole thing. But in fact, the calories that are provided are only for 1/8 of that package is a serving. So in this case, it'd be 2/3 of a cup. And that's 230 calories, not the whole package. Important for us in terms of thinking about the calories that you put in your mouth are clearly important in terms of your being able to maintain weight or becoming overweight. Sodium is another really important sort of factor, particularly for patients who have high blood pressure. Protein in terms of patients who have decreased kidney function, and potassium in the same way. So this is how you read a nutrition label. 4 key things for kidney patients to look at. So how do we translate that to children? Well, nutritional considerations for children in PKD and actually in a lot of kidney diseases in children, there is really very limited research. And so we really borrow the data from adults in terms of PKD from adults with ADPKD. What makes the cysts grow faster? And in adults, we know it's a high amount of dietary acids, so high animal protein, low fruits and vegetables, high amounts of sodium, and drinking low amounts of water. And so if we take this and we extrapolate to nutritional recommendations for children, I think this is a very reasonable sort of approach. So for children who are 0 to 1 year of age, possible use of specialized formulas might be an issue, particularly if they have significantly decreased kidney function. And as we learn more and more about nutrition, you may have relatively good kidney function, but we have enough of an understanding of nutrition in ADPKD in children, ARPKD, that we can tailor the nutritional intake for those children. That's a future consideration. For right now, usually standard formulas and baby foods are fine. For the age group 1 to 3 years of age, this is a critical time to offer a variety of foods. There is a very famous American who I'm not going to dignify his behavior by telling you who he is, that he's really quite proud in his 70s that to his knowledge he's never had a vegetable. That's probably a mistake. It's really a mistake if you have kidney disease, and it's certainly a mistake if you have PKD. So this is the critical time to introduce not just fruits, but also vegetables to children. Encouraging fluids during the day and limiting processed foods. Processed foods have an enormous amount of salt. That's how they maintain their shelf life. 4 to 5 year olds, these are when children start to go to school and they see peer influence. And so their peer may be eating, Lunchables with an enormous amount of salt. Working with the schools to send meals from home, with the cafeteria to select meals together. Allowing children a holiday day during the week, or if they go to a birthday party, so they can fit in and be with their peers is perfectly fine, and allows them then to be more accepting of a more sort of regulated diet. 6 to 12 year olds, water versus sports drink. Water, water, water in PKD. And fast foods, not to say never, but just to say in moderation, and if possible, to ask the local fast food chain, can I have fresh French fries before you salt them? Sometimes a tall order. 13 to 18 year olds, this begins the wild, wild west. School lunches, sports, and they're out on their own. So working closely with the school and with coaches about diet and about water. And then limiting meat, particularly for adolescent boys, to meals. So an adolescent boy might think is a great snack, particularly if they're playing sports, that 1 or 2 Big Macs is a great idea. And then they have 3 other meals with animal-based protein. not a great idea. So trying to just set as a general guideline, limiting meats, particularly animal-based meats versus the sort of the plant alternatives to mealtime. And then finally in college years, where they often have limited kitchen access, that's something to consider. You know, if you have a child who's learned to cook for themselves, has certain foods that they like, et cetera, thinking about their living circumstances so they can continue to do that. Minimizing energy drinks is probably a good idea, because it not just has caffeine, but often they have a lot of salt. And alcohol, talking with your kids about not something being forbidden, but something being managed. And that's a parent-child specific discussion that's important to have as kids get into adolescence, and certainly before they go off to college. In terms of developing a healthcare team for your child, here are some important considerations. PKD is a multi-system disorder. So a nephrologist to manage kidney function and blood pressure, a hepatologist, particularly for children with ARPKD, to monitor for the progression of congenital hepatic fibrosis. Endocrinology, some of these children have significant growth-related issues. Genetics, increasingly we are beginning to learn that there is information in understanding the genetic basis, the specific gene mutations, specific genes that are involved, and the specific mutations that have information about the prognosis of the clinical course for a given individual. Thinking about nutrition, as we've talked about, hugely important. And then psychology. These are chronic diseases. And having children be as healthy as possible in terms of mind-body health, having a good outlook, understanding they are not their disease, but giving them the tools where they can manage their disease and still have the wherewithal to develop into the person that they truly have the potential to be. And then finally, just a word about research. How can y'all contribute to advancing new knowledge in childhood PKD? Well, in 2023, we have research-ready patient cohorts. I mentioned the European ARPKD cohort. We run a similar database in the US, and certainly are very happy to welcome Canadian participants. We also lead in North America the North American component of a global effort to register children with ADPKD into a global database, so we can get some ADPKD in children-specific information to guide our management and our thinking about disease progression. Biomarkers for disease progression that are children-specific, be they clinical, biochemical, genetic, or imaging. We desperately need these to be thinking about not just what's going to happen to children, but to understand in clinical trials, does a specific targeted therapy alter the course of disease because a clinical biomarker or biochemical biomarker or an imaging biomarker changes. And then therapeutics, and there really are two major options here. One is drug repurposing, so drugs that were developed for other indications. For example, tolvaptan was developed for managing the fluid overload in patients that have congestive heart failure. And the pathway that it targets is obviously central to the disease process in ADPKD, so the drug was repurposed. Or developing novel agents because we have new insights about the disease mechanisms. There can be drugs that target common pathways for both ADPKD and ARPKD, and we're beginning to realize, work in our group and other groups, that there are specific pathways that are involved in the disease processes that underpin ARPKD. When we think about clinical trials, for ADPKD worldwide, there are now 23 trials in 2023, looking recently at clinicaltrials.gov. When I gave this talk last year, there were only 7. So there is an increasing interest in developing clinical trials for children with ADPKD. But among these, I must say, I think the one that's most important is, there we go, of children with ADPKD. This is an international effort led by Dr. Jalila Macaulay in Belgium. Current registration is about almost 1,700 patients from all of the continents across the world. The aim is to collect longitudinal data from these childhood cohorts and think about family history, renal imaging, genetic criteria, clinical criteria, so that we can understand the disease better, make better management decisions, and have a clearer perspective on prognosis based on clinical factors. In contrast, in terms of ARPKD, last year when I gave this talk, there were 7 clinical trials. This year, there are 8. This is a much harder disorder to study while we can borrow from ADPKD and the related disease mechanisms, such that potential ADPKD therapies might be effective in ARPKD. The real breakthrough in targeted therapies for ARPKD will be addressing some of these issues. But nonetheless, we are making progress. There are 2 clinical trials. They're very small clinical trials that have opened internationally. One of them is in very young children, 28 days, so 1 month, to 12 weeks, so 3 months of age, to determine whether tolvaptan can delay dialysis in these very young infants. Remember, infants, there's a subset of these infants that if they have very little amniotic fluid, if they have very large kidneys, that they can have a very significant increased risk of going on to need dialysis or transplantation by the first year of life. But this study is trying to determine, can we blunt that trajectory in these young kids? And then there's a study for older kids, so it's a wide range span from 1 month of age to 18 years of age, to understand how we can use this drug, which is a difficult drug to take and to tolerate, in the most tolerated and the safest dose in this spectrum of children. So to summarize, ADPKD is a clinically significant disorder in children. While polycystic kidney diseases are clinically distinct, many disease manifestations are common. Current therapy focuses on supportive management, and clinical trial design for targeted therapeutics, particularly in ARPKD, have been hampered by the lack of prognostic and predictive markers, but research-ready cohorts are beginning to change the landscape. And so I would invite you to consider having your child participate, certainly in some of the database studies, so that we can accrue, can aggregate clinical information from a large number of these children. I'm just going to acknowledge my collaborators at Children's National and UAB. I haven't acknowledged my collaborators at CHOP because I've basically only been there for 6 months. My international and national collaborators, the US ARPKD and ADPKD database collaborators, and my funding. And then finally, I'll leave you with my contact information at the Children's Hospital of Philadelphia and our new Inherited Kidney Disorders program. This is the website. I want to thank you for your attention, and I'm very, very happy to take your questions.
As always, Dr. Guay-Woodford, such a wonderful presentation full of insightful information. Thank you so much for presenting once again and updating us where there were updates. It's absolutely marvelous to have your expertise as part of our summit once again this year. With respect to questions, Dr. Guay-Woodford, we talked last year about the transition of care from someone in the pediatric system going into the adult system. And since we last presented, many families have come to us with those same concerns. We shared a blog from a graduated ARPKD patient who had received a transplant on the pediatric side, and she was graduating into the adult care, and painted a wonderful perception of her journey in making that transition, and talked about things that you highlighted during your last presentation. You know, the beautiful colors and the warm rooms and the overall vibe of pediatric care, and then going into the regular system. Can you retouch on the preparation for families that are
Sure.
about to endure that?
Sure, I would be very happy to, Jeff. I think one of the things that we really need to acknowledge about transitioning is that transitioning as a sort of a scholarly area of focus has been around since the early 1980s. And in certain areas, we've made great progress. Cystic fibrosis is one of those areas, to a certain extent, transplantation, and congenital heart disease. But in many, many other areas, the progress has been much more ad hoc. And I think kidney disease as a whole is that kind of scenario. I think that here really there probably is a distinction between the dominant form of the disease and the recessive form of the disease. Many adult nephrologists are comfortable with ADPKD, and so receiving someone who was diagnosed, I was listening to the previous talk, who was diagnosed with ADPKD when they were 10, and then coming to an adult healthcare system when they're 22, is not tremendously out of comfort zone. And so it is understanding that that in this transition, I think for patients and families, that pediatric care systems are really set up for relatively rare disorders that need a really intensive application of medical care, very often from multiple specialties. Whereas adult care systems are dealing with common disorders that can have a very light touch. And that can be a bit jarring if you're used to that sort of intensive care perspective. I think that one of the things that we are doing in our new inherited kidney disorders program is that we're endeavoring to complement this idea of setting up bridges with adult healthcare systems, provider to a provider, passing the baton, to really thinking about how can we, in meaningful and effective ways, empower our patients to be champions of their own transition. To really understand what kind of information they should know about, to be thinking about things as bold as can they have a slice of their electronic health record that they have agency over, that they can bring to, say, if they're off to college, or if they're traveling, if they're going skiing in British Columbia and they live in Nova Scotia. I don't know the Canadian system, but that might present a challenge. It certainly would present a challenge if you were going from Maine to Washington State, because we have a much more fractured healthcare system. So having a combination of making bridges between pediatric healthcare systems and adult healthcare systems, and empowering patients in terms of not just information, but perhaps even having a slice of their electronic health record. I think at the end of the day, the real issue is that there is a continuum of concerns across the lifespan. And what we have to do is we have to make the healthcare be receptive to that. For example, a kid with ARPKD needs a nephrologist and needs a hepatologist. Most adult hepatologists are not necessarily comfortable with congenital hepatic fibrosis. They understand fibrosis in the liver, for example, from cirrhosis, but it's an entirely different disease mechanism. And so one other thing that we are talking about is, we're now beginning to develop pediatric centers of excellence in the US. Can we provide, through this network of centers of excellence, a network of contacts, people who can be resources to care providers across the 50 US states for these kids with rare disorders that are coming to their attention, sort of to be setting up potential partners in care. So for example, I had a young man that I followed since he was very little, a toddler, who went to university in Montana. There was no care system available to him in Montana that was really comfortable managing his ARPKD. At the time I was in Washington, I didn't have a medical license in Montana. And so we had to do this very convoluted kind of, rigmarole to really get him the information that was needed to provide him with care. I think that we have to recognize that PKD, by and large, certainly in children, is a rare disease. And we need to embrace, how do we transition as a whole rare diseases that need so much intensive care to adult healthcare systems where there is not necessarily the framework, not necessarily the knowledge to do this. And I think the patient and the patient-centric approach is going to be key to doing this in the next couple of years.
That's amazing insight. Thank you for going into such depth. Knowing you for as long as I have, and the impact you've had on so many families globally, I know you can appreciate this next question, and it's surrounding, again, the support for families who are newly diagnosed. We know that there is a wide range of emotions during the pregnancy, throughout the process, and whether it's prenatally or upon birth, when one is given the news of either an ARPKD or ADPKD diagnosis, things can be uprooted. What guidance from your standpoint would you recommend for families that have been given that news in those early stages when there is a lot of fog, a lot of chaos, a lot of Dr. Google that can work to our detriment, of course? What would you recommend to help slow things down for those individuals to know that they, or to help them get the proper steps of care in place?
Yeah, I think that the most important thing is in our zeal to understand, to be sure that we have the right sources of knowledge. So going as someone brand new to the field to Google to understand ARPKD is, quite frankly, horrifying. And so I would encourage, as I have, the PKD Foundation in the United States, and Jeff, you and I have talked about it, the sort of the patient groups. There is this incredible network of families that will hear about things. And for the patients in the audience, the families in the audience right now, what I would say is, don't have those groups take the place of your physicians and expert physician care. But by the same token, your physicians and your care providers haven't walked in your shoes as families. And so you need both. You need the peer-to-peer mentoring, the peer-to-peer support that you can get from other families and other parents. But you also need to have accurate information. That's why in the United States, we have moved towards pediatric centers of excellence for care, not just for families, but also for our colleagues that, may see one or two patients. Who can they, call? Who can they contact to say, I have this situation, what do you advise? So I think making yourself or availing yourself of the resources of family groups and expert physicians is really, really important. There will be a tendency, because it's easy, and at 2 o'clock in the morning when you have a question, Google is there, your peer colleagues and your physicians are not. But to be careful, because once something hits the Google, it's there forever, even if knowledge changes.
Absolutely. That's wonderful advice to end on. Dr. Guay-Woodford, it's an absolute honor to spend time with you. Thank you again for your continued support of the PKD Foundation of Canada, the amazing work you're doing across the border. It's been an absolute privilege to spend this time with you again today.
Thank you very much, Jeff, and it's always a pleasure to join my Canadian friends.
Love it. You have a great Thanksgiving next week. I know it's turkey time for you guys. Wish you the very best, and we'll be in touch soon.
Great. Thanks so much.
Bye-bye.